Welcome to the body imaging cases. This is a 45-year-old female with acute abdominal pain, nausea, and vomiting. Abdominal radiograph in the erect position showed no evidence of intestinal obstruction. Contrast-enhanced CT of the abdomen and pelvis revealed a rounded lesion at the right side of the abdomen, which contains fat. We may need to manipulate the window of the CT images to differentiate between fat and gas. So the presence of fat here is impressive of mature cystic teratoma, dermoid cyst. The question has been if this is a retroperitoneal dermoid or a mesenteric dermoid, because a retroperitoneal dermoid is very unlikely to be a cause of pain, considering that it is fixed to the posterior abdominal wall, and in this case we may need to search for another cause of the acute abdominal pain. On the other hand, a mesenteric dermoid is very likely to cause pain because of its mobility within the abdomen. To answer this question, MRI has been performed, hoping that the lesion may show some degree of mobility between one sequence of images and the other. But in fact, the lesion has completely moved from the right, as it has been on CT, to the left on the MRI, which proves its mobility and proves also that it is mesenteric rather than retroperitoneal. And the presence of small intestinal loops posterior to the lesion definitely excludes its retroperitoneal location. This is the fat on the T2 weighted images and is suppressed on the fat saturated T2 weighted images. This is the appearance of the lesion on the diffusion weighted images, showing mild diffusion restriction. And no enhancing solid components. So the diagnosis of mature cystic teratoma or benign dermoid cyst is made. This is a three-dimensional reconstruction of the CT. The lesion is shown to the right of the mesenteric vessels. We see how the jejunal veins, which are normally directed towards the left side, are making a turn here together with the mobile lesion. We see here that the upper jejunal vein is making a loop which is not made by the other jejunal veins, which localizes the lesion not only to the mesentery but exactly to the upper jejunal part of the mesentery. The diagnosis is mature cystic teratoma of the mesentery, mesenteric dermoid cyst. Mature cystic teratoma is identified by its fat content. Manipulation of the window setting may be needed to differentiate between fat and gas. The mobile nature of the lesion and the presence of small intestine posterior to the lesion are two signs of mesenteric location of the lesion, which exclude actually the retroperitoneal location. The relation of the lesion to the tributaries of the superior mesenteric vein could identify its location within the upper jejunal mesentery.